Well, hello everybody. A very warm welcome to this evening's webinar, Royal College of Surgeons of England. It's human factors and it's breaking hierarchies tonight. And I've got some great speakers with me this evening. I want them to introduce themselves first of all. Ginny, then John, and then Peter, in that order, please. Ginny, first of all.
Hello, I'm Ginny Bowbrick. I'm a vascular consultant at Medway Hospital in Kent. I'm head of School of Surgery for Kent, Surrey and Sussex, and I'm the incoming chair of the Vascular SAC.
And then John.
Hey, I'm John Hardy. I'm a trauma and orthopaedic registrar. I suppose I became interested in human factors when I did some flying training with the RAF, and then have continued since in the civilian world, and just to see really the lessons that we can learn from other industries.
Great. And Peter.
Hello everyone, my name is Peter Brennan. I'm a maxillofacial surgeon based on the South Coast. I've had an interest in human factors probably for about the last 9 or 10 years. Published about 90 odd papers now on HF, many with John actually, and a recent PhD on it as well. And I'm an elected member of the council of the RCS as well.
Great, okay. I wonder if I can have the next slide, please. Are hierarchies all bad? That'll be one of the things we'll be discussing this evening. Here's the lovely picture of the college all lit up. It actually is looking slightly different at the moment because it has been completely cleaned. It's got an extra story on the top, and we've just signed the contract, and we will be moving in the next few weeks. Probably first major public engagements, virus permitting, sometime during September. And I hope you'll all come and see it because it's going to be absolutely fabulous. When I first got on the council of the Royal College of Surgeons, there was definitely a hierarchy. I can tell you, I was absolutely terrified. I took several council meetings to completely understand what was going on. And then even then I was terrified to say anything. And I think it took me about a year and a half before I could actually stand up and actually say anything about a particular issue. And that was probably a misperception of mine. It wasn't necessarily that they were all hard and tough and I was too little to speak out. It was partly my perception, I think. Of course, some surgeons have had particular reputations in the past. Not only Lancelot Spratt, for example, in Frenchay Hospital in Bristol, there was a famous thoracic surgeon named Belzy, who gave his name to several hiatus hernia operations. You did hiatus hernia through the chest in his department, and he was famous for keeping absolute silence in theatre. In fact, on all 4 walls of the theatre were signs saying silence, operation in progress. Absolute silence, absolutely no doubt either that he was in charge and he was the boss. And the story is told, probably apocryphal, that he was standing with the senior registrar on one side and the junior registrar on his right-hand side doing one of these cases. And the junior registrar said, excuse me, sir, can I please ask a question? And Belzy carried on doing the operation, completely ignored him. And then he said again, please, excuse me, sir, can I please ask a question? Belzy ignored him for the second time. Eventually he said, but please, I really must ask a question. But Belzy said, well, what is it? He said, excuse me, sir, you've been standing on my foot for the last hour.
Brilliant.
Probably apocryphal, but still worth telling. Of course, if you were to go to mainland Europe, particularly some of the German centers of surgery, they have a very clear hierarchy. There is the boss of surgery, and although it is slightly changing, all the junior consultants below the boss and the residents would be given the cases they're going to do that day or that week. Absolutely no question who's in charge. And we've also all met colleagues, for example, a famous anaesthetist when I worked in Bristol, a knight of the realm. He had very high standards. And although he would brilliantly get the patient on the table very, very first thing in the morning, by the time he did, the atmosphere was so poison, it was impossible for anybody to enjoy themselves. So is it necessary to have high standards going hand in hand with a sense of fear in the operating theatre, which makes it difficult to speak up? And we're going to be talking about all those issues shortly, and I'm going to ask Peter Brennan first if he'll present a few slides to set the scene. Peter.
Thank you very much, Neil. Could you move on one more slide? Thanks. So, I mean, Neil, you just epitomise hierarchy really, and it's not just about whether there is a real hierarchy; it's about perception. And certainly now at the Royal College of Surgeons of England Council, Neil is fantastic. We're allowed to address him on a first name basis. We can call him Mr. President. And he actually empowers the council, so he will go around and say, has anyone got any more points? Please speak up. Absolutely amazing. So it's all about perception really. And if you were this person on the right on that slide there, would you feel able to challenge the person on the left? Yes, there has to be a hierarchy, and Neil's already touched upon that, and very steep hierarchies, very flat hierarchies. We're going to talk about that as well. That's almost worse actually, in that no one knows who's the leader, no one knows what's going on. But when you put on a name badge, be that consultant or specialty registrar or matron or whatever it is, you are instantly creating a hierarchy to someone slightly more junior than yourself. And what's important is to reduce that hierarchy, not eliminate it, but reduce that such that anyone can speak up and challenge you if they have any concerns about the case. And what's really important is doing that without retribution. So, you can speak up and you might have a point which might seem silly, but it's without fear and it's without retribution that you're going to get told off for doing so. Can you move on to the next one, please? Thank you. So, I mean, we're going to talk a little bit about briefing, and I think Ginny and John, you'd actually agree. It goes one step sort of ahead of that really. So whenever a team member starts and joins the team, that is the time to start reducing hierarchy and introducing yourself, telling your new registrar or whoever it is, that they can speak up, come and speak to me if you have any concerns and so on. And I think that's just really important, and we emphasise doing that throughout the operating list as well. And John, I think you're going to talk about a paper we're just about to publish about mini briefs, which again, it's really, really important. And I think you should engage with the checklist as if your own life or limb depends on it. And I mean, yes, there's WHO, but the number of never events are still increasing, believe it or not. And why is that? And one of the reasons is because we don't engage with checklists as if our own life depends on it. It's a tick box exercise. We'll touch upon situational awareness and talk about the what if scenario, so we're not having that kind of startle moment. I mean, Neil, you mentioned about distractions and silence in theatre and things. I mean, that's certainly something we can talk about if you want. What some people might like of having complete and utter silence, the rest of the team might not like that. There are safety critical times when, of course, you do need to concentrate. But all of that needs to be agreed by the team rather than the consultant insisting that this is how we're going to do it. And I think it's really important that we take regular breaks. Again, Neil might be able to work for 9 hours non-stop, but that doesn't mean that the rest of the team feels exactly the same. So it's really important to agree when we're going to take the breaks, optimize our performance, hydration, nutrition. Next slide, please. So again, we've looked at many organizations, and I think it's really important, you cannot compare aviation or rail or the nuclear industry to healthcare. You just cannot. However, there's something in common, and that's the human element, and you can bring the human factors that some of these organizations have learned and apply those into the operating theatre. So say, for example, here you can see on the flight deck, they have a very shallow hierarchy. So of course the captain may have many thousands of hours of experience, and the first officer might be very junior, but that first officer can actively speak up and challenge if he or she has any concerns at all about the flight. That's really important. Right, next slide, thank you. So we're going to talk a little bit about how we can go about reducing authority gradients. I mean, people talk about putting your first name on a hat and your title there. There is no published evidence that actually reduces hierarchy. What it does do is it obviously improves communication. So the person on the right is Matt and he's anaesthetist. But but he could be the most objectionable colleague there is. He could be rude to you. He could be very steep hierarchy. You have to actively reduce that gradient. So having your first name on a hat doesn't actually do that. Next slide, thanks. A very short article we published in the BMJ about 2 years ago, and this is just all the things we're going to talk about tonight. I mean, that's freely available, and just simple common sense. Most of human factors is, in my opinion. And how many times do we leave common sense at the front door when we come to work? Next slide, thank you. And finally, I think this is my last slide. Finally, it's all about respect. So you earn respect. So the president has a certain amount of respect for being the president of the Royal College of Surgeons, no question about that. However, he will gain even more respect if he empowers the council, he empowers colleagues, he empowers trainees. People will respect him more, and then that goes round, and then he will respect, or he or she, and then that just goes round. So respect is actually earned, and that's really, really important. Really important to stress that. I think that's the last of my slides, Neil, actually.
Yes, okay, Peter, thank you very much. And you are allowed to call me Neil. That's absolutely fine. I'm going to ask first of all some comments on those slides from Miss Bobrick. No, Ginny, first of all, Ginny.
It's interesting that, because women are very particular about being untitled, and there's been many times when I didn't challenge it for many years, and there'd be a list of consultants with me as the only female, and I'd be the only one without my title. So I think I don't mind if I don't have a title, as long as everyone else has got theirs dropped as well. And I think it's important that we make that distinction within that. But a lot of what Peter talks about, we've been doing for years and not knowing we were doing. Well, some of us have been doing for years and not knowing it was human factors, making sure that our juniors get a break, making sure we get a break. I mean, we all know a femdistal can go on for about 8 hours, much to the anaesthetist's unhappiness. But it is important that you find a point when you can stop when you're doing those sorts of operations. And what's really good is that the culture is changing. And I think if we feel this wave of culture changing, to say that this is acceptable.
Yeah, I mean, I would. I'd just come back to you, Ginny, if I may, and just say, for those who will work for 9 or 10 hours non-stop, would you drive from London to Scotland without taking a break? And almost everyone says to me, no, I'd stop in Manchester or Birmingham, whatever. So why is it right then to actually be able to operate for 9 or 10 hours? Because it's a cultural thing. It's not physiologically safe. You start to reduce cognitive function as you evaporate water. You become hypoglycemic. All sorts of things come into play. So a change of culture, Jenny, as you said.
So, John, any comments on those slides first of all?
Yeah, well, I suppose the title of the webinar is Breaking Hierarchies, which is a very catchy title, but really what we're trying to do is reduce hierarchy gradients, I suppose, which is a less catchy title, but actually what this is about. I mean, certainly as a trainee or anyone in the team, you need to know what the skills that people have, and that's reflected in their job title. And you need someone to make a decision. You have to have a captain of the ship or the aircraft, or the consultant who is there to make that final decision. But you also don't. I mean, I don't want to be there as a trainee standing quietly as I'm going to watch my boss cut into a major vessel that they might not have seen. You don't want the ship's watch there looking at the rocks as the captain goes and steers the ship into it because they're too scared to speak up. So it's about getting that balance, really. So I think my main point here really is it's about reducing gradients, but it's a balance. It's not a free for all, and someone still needs to make a decision. And there's a reason that the hierarchy has developed over years in medicine, and we can still use that. It's great for distributing tasks and for knowing what people need to be doing and what their responsibilities are. But we do need to reduce those gradients.
So reducing hierarchies. Ginny, I'm going to ask you, is there a difference between hierarchies in theatre and in the committees and the meetings we have and the wards and the clinics? Is that a different situation, or is it all the same thing?
I think that in any of those situations, there is a hierarchy, but it's, as we say, it's empowering those people to contribute to it. So in theatres, you know, you're the consultant, and ultimately, if something goes wrong, you're the one that carries the can, and you're the one who may be guiding a registrar through it. I think if the registrar felt, or trainee felt, that you weren't in control, I don't think they'd feel at ease to be operating. So, you know, all these situations need a hierarchy, and a meeting has to have a chair, otherwise there's no direction to that meeting, let alone no one keeping the time, and it overruns. But I was thinking, you know, as a vascular surgeon, we're very much the phone a friend if someone hits a vessel, like you said, John, and we get called. And the one thing that you tend to do as a vascular surgeon when you walk in is to pack the wound, let the anaesthetist catch up, let everyone catch their breath, let everyone down, and then you can start. And that's as a new person in the team, you come in, but you just try to regain that sort of situational awareness of what's going on and let everyone calm down. And you're just thinking that when you said that, John, about that sort of situation. So you do need to have someone in charge, but it's being open to suggestions and allowing people to make suggestions to you without telling them to stop talking.
So, Ginny, can I just ask to press you a little bit further? Apart from the brief at the beginning and everybody introducing themselves, once you're in theatre, how do you set the tone that allows people to feel comfortable to ask questions and say stuff? Is it just a matter of personality, or do you actually actively do something? How do you manage it?
Well, I guess it's lucky that having been in one place for 15 odd years, that does make it easy because people know you, and that can be a difficulty for trainees moving around 6 months or yearly and having to be part of a new team and get to know each other and everyone know where you stand on things. But I like to have music in theatre. And I sort of make sure that everyone's happy with that, but I do like to have music, not too loud, but then I make aware that there are times when that music has to go off and people have to concentrate. I'll communicate with the anaesthetist. I think a carotid endarterectomy is a really good example of a case where you have to be in continual communication with the anaesthetist as to what's happening through the operation. And I think that makes everyone feel that you're all communicating as a team, you're working together, and people contribute to that. I mean, I'm sure that Peter can think of operations he does where, you know, the communication is all communication is key, but there are some where it's actually imperative. So
yeah, I mean, yeah.
So Peter, just the brief, or does it need more than that?
Well, I think it's 90% of communication is non-verbal, Neil, as you know. So it's, you know, it's the way you conduct the brief. It's, you know, if you have your arms folded like this and welcome everyone, you know, that immediately, you know, sets the wrong tone and the wrong impression. So, you know, it's about the way to go about it. It's about before you even come into theatre, you know, it's about maybe do the brief. If there's time, taking your trainees off for a cup of coffee. That's what I will do. And sometimes the nurses will come with us as well. And that, you know, the power of that is just immense. And asking everyone to look out for us, and, you know, please just stop me if there's anything you're unhappy about. Please keep an eye on the time. That's important because, again, you can get tunnel visioned, Neil, as you know, if you're concentrating for several hours, time just goes past really quickly. And John, maybe you can just talk about this PPP paper that we're about to publish as well, if you're happy, President.
I'm very happy, sir.
Thank you. Sorry.
Yeah, it's very interesting actually. You were talking about when the first thing you do in vascular surgery is that you get to a place of safety, and that's a really powerful tool. I mean, people are often too quick to rush into trying to get to a solution, whereas actually there's something you can do which is a very simple intervention, which then means you can stop and you can listen to people. And Peter and I have written a paper, which is something we've adapted from aviation, and it's a tool that pilots can use if they lose all situational awareness and they're not quite sure where they are. So the equivalent is you go and climb to height, so you don't go hit anything on the ground, and you make sure that you're safe. And then you can stop and you've got time, and you can sit on your hands, and then you can get everyone who is, you know, there in the cockpit, the same as, you know, everyone in theatre, and you can think about three different things. We call this the PPP brief. So after you've packed the wounds, think about the patient. So ask the anaesthetist, say, where are we at the moment with the patient? Is everything safe? Have we got any blood loss? The procedure, do we need to change procedure? Are we doing the right thing? Is there something we've done in the pre-op plan that we didn't think about and we could look at now? And then people, do we need someone else? Do we need to phone a friend, as you said? If you're the trainee, is it like, well, maybe this is now the time to call the boss? And this is also, when someone else in the team, maybe your scrub nurse goes, yeah, these are the people that actually would be really useful, or actually we've got the rep next door and they know how to use this. So it's really simple, but that's a way to improve your situational awareness. But also actually to lower hierarchies, because you allow everybody with quite an open question a time to contribute and try and find some solutions.
Okie dokie. So Jane has come onto the screen and is clearly wanting to get us to answer some proper questions. Jane, have you got some questions for us, please?
It'd be great if I just said no now, wouldn't it? No, we've got lots of questions coming in thick and fast. One day. Excuse me. So we've got a couple of comments, which I'll start with. Lots and lots of positive comments coming through. So somebody has said, so what we're looking at here is that competence hierarchies should not be in conflict with communication. Is that the sort of basic message that we're putting across?
Anybody want to answer that? John, do you want to answer that?
Yeah, I think that clearly the thing with human factors is everything's very interlinked. So it's sometimes challenging to tease things apart. And you look at one aspect of it, and another aspect of it then becomes apparent. But competence, of course, is quite a difficult thing to tease apart. But if you're talking about someone's skills and someone's experience, certainly that's quite different from trying to actually have good, effective communication. So if you're an observation from someone in theatre, they may not be able to necessarily interpret it because they don't have the experience and the training necessary to back that up. But they should be listened to, because that observation may be interpreted by someone further up in the competency hierarchy, as you might put it, and that might be a really important observation. I think the other important thing with that is that all observations are valid, and they may not be correct because they might not be interpreted correctly, and that's where you maybe need that competency. But it's valid, and if you receive some information from someone, it's quite easy to without realize it, to dismiss somebody. So someone from theatre maybe points out, are you going to do this? And you go, yes, of course we're going to do that. Yeah. But actually, maybe what you should be saying to them is, well, yeah, thank you. You've observed that, but actually, this is what we do. That's the next step. And that encourages people to be your eyes and ears, I think. So it's about communication. It's about observation. It's not necessarily about interpreting those, but either way, we should be thanking people for those observations and using them.
Can I just add something to that question? Because a couple of months ago, I was doing retroperitoneal approach to the iliac vessels, and my trainee said, "Oh, have you tried this gadget? I think an O-ring or something." And I'd never used it before because it's used in laparoscopic surgery, and popped it in, gave me the best exposure to the iliac vessels I've ever had. And we're never too old to learn. And when we talk about competency hierarchies, are we saying that we get to the point where we don't need to learn anything else? Our trainees bring us so much in train us, not train us, but teach us things as well. And if you've got closed ears to that, then you're never going to experience those opportunities. So I think we're always continually learning.
And if I could,
no, sorry. I always say it's a bad day if you don't learn something new. And the trainees may have read the latest papers on what have you, or they may have just done their exam, and they will understand far more up-to-date knowledge perhaps than perhaps we do, Jenny. To be honest, So
it's the pleasures of having trainees where they bring in different skills. So competency hierarchy, it's competency based on what? By experience or by new techniques or by knowledge or reading papers. I think there are many different hierarchies in competencies that you can look at, and perhaps it's the wrong term to use.
Yeah, I think what you're all saying is we've got to be humble, and it's lifelong learning. And I think you're absolutely right. We miss a lot if we're not open to that all the time. Yes, Jane, next point.
Super. We've got some really good questions coming through. I'm going to try and get through them.
We're
So,
scared. We're scared, Jane.
no, they're really good ones. I like them. It's going to be hard to pick. So somebody has said, do you think the introduction of clear masks into the operating theatre would help break hierarchies or improve communications in surgical teams and encourage juniors to speak up? They continue to say that some of their hearing impaired colleagues have introduced them to quite successfully. So yeah, non-verbal communication, has that got a place in theatre?
So I think, the short answer,
during the PPE problems. Yes, sorry, Peter.
No, sorry. I mean, this is one of the difficulties, isn't it, with online? You never quite know who's going to speak. But I mean, non-verbal, as we mentioned, it's 90% of communication is non-verbal. John and I have actually published about PPE, in fact, last year, and in fact, it's one of the most downloaded papers. I think it's 150,000 downloads, John, isn't it? Something like that. And it does. If you have full PPE, and I think the picture is me wearing operating loops and things, you are losing most of those factors, Jane, that you can't see. So the short answer is yes, and you have to empower the team at the start and say, look, we're wearing PPE and things. If you say something and I don't respond, that may be because I haven't heard you, or you need to be extra vigilant. That's basically the summary of the paper, John, I think, isn't it?
And the other thing I think that we did also write about is that it's really quite important when you're wearing PPE, especially when you're wearing masks, visors, to try and reduce the ambiguity in what you're saying, and to complete the feedback loop when you're communicating. And it's difficult to concentrate on that the whole time for a whole operation. But there are certain safety critical points where we have to realize that things like PPE might be stopping us communicating properly, and to make sure that we are addressing people by their names or their roles, so we know who is meant to be doing the task. That might be a time that we say, well, actually, maybe we should go and pause the music for a moment because we're getting to a critical part of the operation. This is almost the sterile cockpit idea. So certainly not for the whole operation, because actually it can improve surgical skills, actually having some music that gets you into the flow of it and that flow state. But there are certain points in operation you might want to put it on pause and say, right, we need everybody listening. And again, trying to reduce ambiguity in what you're saying. So you could say, all right, can someone get out the cement or something like that, or we need to get ready to mix it. And by that stage, the scrub nurse is there mixing the cement vigilantly away, but you never really asked them to do that. You just said, oh, we just need to get it out, ready to mix it. So don't say the words. Think about what you're saying a little bit. That's again an idea. That's an idea that you get from a lot of radio work, and air traffic controllers never say the word take off. If someone says I'm ready to take off, someone said the word take off, and someone might just go and take off, and they haven't actually got the clearance to do it. So everyone uses the word departure. You're only allowed to say departure, and it's only when you're ready to take off that someone allowed to take off. So you use those ideas in theatre. So instead of mumbling those words and say, right, can somebody get the thing? Especially when you're wearing PPE, can someone go get the thing? And you get more and more frustrated because the person isn't getting the thing. And say, stop for a moment, realize that no one can really hear each other, and just say, right, Peter, if you could please, get this particular item for me, and then you also complete the feedback loop because they will say, yes, I'll get that for you now. So just these simple techniques, really, and I suppose none of it really is particularly complicated, but we just thinking about these simple principles can be very helpful.
I mean, I think,
Ginny,
John.
Sorry, I was just going to ask Ginny, the clear mask then, a gimmick, or do you think we should advocate for it, press for it, shout for it?
Well, I mean, I'm not from the perspective of our patients. I mean, I've had some patients come in who, in the clinic, and that's what we all have, who've got hearing difficulties and who are lip readers. It must be incredibly difficult for them. I'm not sure that that my trainees would be lip reading me, and if I'm not lip reading them, maybe sometimes I don't want to be lip read what they're saying. But I think it may, from my perspective, I think it would be a bit of a gimmick. I don't think that we would benefit from it. anymore, because unless we're hearing impaired, I can't see the benefit.
I guess if you had members of the team who were hearing impaired, you make special arrangements for that theatre. And again, it's being open and understanding of everybody in the team. Jane, next question, please.
Just to flag that the lady who was asking the question is hearing impaired, which I think is where it's come from.
Yeah.
And
yeah.
yeah. Oh, she wants to be a surgeon. Well, it shouldn't be. I'm gonna take a stab. So there is a need. Okay. That's where that feedback comes in that case. But that's the sort of adaptation you would make for an individual, as opposed to a blanket change to the organisation. Is that how I would understand that?
I don't know. I think my view would be anything you can do to improve communication has to be correct. So I mean, John was talking about the thing, and I think we use pronouns all the time. I'm going to get it, or I'm going to give that, or whatever. And you need to use proper nouns. So I'm going to give this drug, vincristine into the spine, or whatever it is. So that's really important. But personally, I think clear masks would improve communication actually, and so we agree to disagree, Jenny, I guess, slightly. Healthy.
I guess it might happen in time anyway if the cost comes down and we can get them from China easily. Oops, sorry, Jane.
Moving on. How much of the hierarchical gradient do you think comes from surgeons, and how much do you feel comes from the management and leadership of an individual trust?
Well, that's a good question. Peter, do you want to start this one?
I was hoping you weren't going to ask me that, to be honest. I mean, it's not just surgeons, Jane, either. It's you can have a matron on the ward that can have the very steepest hierarchy to the foundation doctors or medical students, whatever, and people are scared of that individual. I mean, I think human factors understanding it needs to be a top-down and a bottom-up culture. So it needs the Royal College of Surgeons, it needs chief executives and managerial staff to understand human factors and apply it, and of course it needs us as deliverers to understand and provide as well. So I think there are going to be conflicts between managers and hierarchy within organizations trying to push the numbers through, particularly as we come out of the pandemic. It's a difficult question to answer in such a short time, Jane, to be honest, but we need to work together, and we need to look at those holes in the Swiss cheese and actually block those holes at a higher level, up at an organizational level, before we even come down to our own level. So that's I think probably how I'd answer that.
Do you think there's a reference to the stereotypes here, the stereotypical surgeon that Neil mentioned at the beginning, Sir Lancelot, Spratt, and wanting that hierarchy? Is that a reference to it? Because I feel that stereotype is very much changing, certainly over my career. And I think that's a really positive thing. And there is a reflection that really the whole culture of the NHS is changing to be less hierarchical and more inclusive in every way. So I wonder if that was a reference to that.
Yeah.
And I think there is a sense in which we need to understand each other's point of view. The management, let's say, as a gross oversimplification, marches to a different tune on the whole from the professional. And it's really important that each other understands the other point of view to make the place work best. Obviously, if you're running the hospital and the government's saying you've got to do this by then, and the professionals saying, actually, we haven't got the theatre staff and we haven't got the team and we can't get the throughput going because we're still using infection prevention control, there needs to be a conversation. And again, if the hierarchy is flatter, as John has said, that's going to be easier to have that conversation, I think.
And it's about mutual respect as well, isn't it? Just as we said, that final slide, it's about everyone respecting everyone else, irrespective of your grade or your title or your position. Mutual respect is so important.
Yeah, Jane, please.
Super. Somebody has come in and said, I suspect that most of the audience today are fully invested in levelling hierarchies, which I think is probably a fair assumption. What advice does the panel have for getting our sceptical colleagues on board?
Oh, that's a good question.
There's some really good ones.
And for example, there are those who say that if I am expecting the very, very highest standards, and there are some surgeons who give out that aura, they may be more difficult to engage with and to speak out with. How do we somehow combine those two things? Any views? John, do you want to crack off on this one first of all?
Yeah, so I suppose there are two sides to this. One is how do you get those people to subscribe to this? And there's a huge amount of evidence from a lot of other industries and increasingly in surgery and medicine that hierarchy gradients can be dangerous. Even if you look at something like Korea Air, they had one of the highest accident rates in the world, and that was because the first officers, it was not culturally acceptable to point out anything that was going wrong, and not even an observation. So that the captain could fly the thing into the ground, and the first officer would vigilantly stay quiet. There's more purely experimental data as well. I think the very important early study was the
Have we lost
John?
We've lost John.
For a second, yeah.
study in the 1960s, where they set up a hierarchy gradient, and they sorry, I think I lost you there for a moment.
You dropped out, John, halfway through, I think. Yep.
Can we just come to? Can we come back to Ginny?
So I think the other.
From the perspective of who's listening and who's invested in this, I mean, our trainees are going to be very invested in this, because the GPCs, the generic professional competencies from GMC, include human factors, situational awareness, bring out the team working. You've got the domain of professional behaviours. So they're all going to be, or they're going to be very much up to speed on it to be signed off to get their CCT. It's us dinosaurs, that's us who are older, who haven't had this in their training. We didn't have communication training, we haven't had situational awareness, human factor training. But the evidence is really compelling. You just need to look at the information from the invited reviews from the Royal College of Surgeons and see where the majority of poor functioning units, where there was poor patient outcomes, it was poor communication, poor team working, hierarchies. And you only have to look at the evidence that's presented to you to understand, unless you're so obstinate that you don't want to accept it, that this is the way that the culture has to change. And this is the way that we have to change as surgeons, and accept that this team working, communication, all of this human factors is so important for our patient safety. We need to come back to what's important for the patients there at the root of it. And I think if you're in denial, then that's a big question to ask yourself, why you're in denial when the evidence is so clear.
There are lots of fantastic cases which I think are probably going to be discussed in the webinar tomorrow. The CORES cases, which are all from surgery. And if you look at some of the reports, that time and time again, going back many years, there is evidence saying, well, if the hierarchy was flatter here and actually somebody listened, then this medical and surgical disaster wouldn't happen. And so I suppose that's one side of it, and the second side is how as a trainee or someone who is concerned about something, how in that situation, if you've got someone who isn't buying into this, do you start raising a concern? There's a little mnemonic which is PACE, which I think quite a few people have heard of, where it's all about respect, because no one's going to listen to you if it isn't respectful communication. So we start with probe, and you think, well, are we doing the right thing here? Maybe there's something that I'm missing. Maybe there's something we can learn from this. And if still someone's not listening to you, you say, well, you alert them and say, I'm a bit concerned, this doesn't really seem to be working well. I think maybe we should stop, or we should be doing something else. And then you could maybe challenge directly. And finally, if after having been challenged directly, someone's still not listening, you're really worried, that's the time to escalate and say, right, it's time to go and get some other help now, just to get another set of eyes. And I think there's a really respectful way to do that. And there's a way to escalate your concerns. And you can, I think the main thing is, everyone's learning all the time. So that's a great way to start off, and a great way to approach this, to say, from a learning point of view, where are we with this? to ask those open questions. And if you're concerned, you can always escalate.
There's also, John, there's the so-called CUS technique, which was designed by United Airlines, and it just basically uses 3 words. I'm concerned would be the first one. I'm then uncomfortable is the second one, and finally you say I'm scared. And so they're kind of provocative words, and they actually work quite well. So either the PACE or CUS would be a method, I think.
Can I ask, John, have you ever used PACE or CUS as a registrar with any of your seniors?
I have, and they're cases where eventually they were, sometimes you get an extremely difficult case where you can see that someone's losing situational awareness, and often these are out of hours operations where someone has, as we say, it's been added onto the end of a list. They think they've got other things going on. They feel they're aware that they're meant to be elsewhere. They're tired, they're hungry, they're dehydrated. All the theatre staff are ready to go home and go, come on, and they're getting more and more locked into what their particular and getting tunnel vision as to whatever technique they're using. And I think this is where you say, well, is this the right thing, or can we maybe change approach? And it's just trying to get somebody out of that rabbit hole and out of that tunnel vision. And I think eventually I said, well, actually, next door there's so and so, and I know they've just finished. So shall I pop through and ask them? And there's a really respectful way of doing it. And I sort of popped through, had a quick word, and said, look, this procedure, it's hard, and it's the end of the day, and we could do with an extra set of hands. And so we got another set of eyes, and very, very respectfully, we managed to get ourselves out of that situation. It doesn't have to be I'm really concerned and worried about this, and I think something's wrong. There are other ways to do it. I think it's about, as I say, starting from a level where you probe and ask, and eventually, if you need to escalate, you don't have to make a big thing of it. Just go and do it and be respectful about it, and that respect then flows both ways.
John, very diplomatic. You'll go far. Jane, next.
So that was very diplomatic. So is there ever a danger that is there a danger of too flat a hierarchy in surgery?
So Peter, do you want to start with that one?
Yes. Okay. So there's basically three types of leadership, I guess. There's the autocratic form, which is basically a dictator, that a little bit like your Lancelot Spratt character, Neil. You've then got the democrat, which I think probably all of us aspire to seek views of the team, to empower everyone in, and then you've got the laissez-faire, which is basically no one knows what anyone's doing, and that is particularly dangerous. And there are studies published on this, both in terms of the team not really knowing whether the lead surgeon is actually capable of doing or not making decisions, and no one quite seems to know. And you lose situational awareness, you lose communication, because you start talking about things, and your attention drifts maybe to something else. And John, I mean, you mentioned about human factors. So we're doing some work with a chap called Steve Jarvis, who's a human factors expert, advises the CAA, works for Air New Zealand. I mean, he may well be joining us this evening. And basically, what Steve says is that you've got a balloon, and that's human factors. And if you press on one part of the balloon, another part expands. So you have to take them all together, Neil. But yes, laissez-faire is very, very dangerous, and there's a number of studies published on that.
Ginny, can it be too flat?
I think that yes, it can be too flat. They need to have someone in charge, someone to make that decision. You can have a number of suggestions coming, but ultimately someone's got to make the decision as to which of those suggestions is the best. That's that one person. But we're talking about the different styles of leadership. It's interesting how leadership's changed from being the most senior person in the department was always seen as the best leader, rather than the person who's actually got the best leadership skills. That sort of view is changing, so we don't end up with all autocrats. that Peter's mentioned.
Yeah.
Okay, Jane, next question, please.
Had to happen. I was on mute. Sorry. What are your thoughts about culture and diversity and its effect on the authority gradient?
Yeah, Jenny, can you come on that one first, please?
Yeah, I mean, from the perspective of being a female surgeon, there's definitely been a change in how authority is being viewed, and I think that that's a good thing. Not to be dismissive of women or ethnicity or other forms of diversity, and the acceptance with that. And to look at the Kennedy report, I'm sure that Neil can recount that word for word now, and the actions that the college will take, and that's a good thing, to address those issues. But I can, even over the years with women in surgery, for me, there's been a change in how we're viewed and the authority that we have. But yes, it's when you walk, it's not just with other surgeons, actually, it can be with patients, it can be with other healthcare professionals. And a number of times I've walked into a room to talk to a patient, and they've only wanted to talk to my male or house officer F1 as if they've done the operation, and rather than I've counselled them, I've done the operation, I've gone to see them post-operatively. So it's not just with it, it's in many different environments and not just amongst surgeons themselves. It's educating everyone. But I feel a change over my 30-year career, and hopefully the Kennedy report will help.
Yeah, and John, what do you think?
I think more generally, talking about culture, I think clearly there are the diversity elements which are incredibly important, but also generally safety culture, which is a huge topic, is something where all of this fits into it. So having a just culture, where you can learn from error, where you can learn from when things go wrong, is really important. Now, that's not saying it should be a no blame culture. That's clearly incorrect. But also having a punitive culture where any time that you speak up about something, you're going to get punished or you're going to get called out for it. And that doesn't necessarily mean that you're actually going to be hauled up in litigation. That also means that you might be embarrassed in front of your colleagues, and you might not want to speak up about something again. It can be these almost microaggressions that will stop you doing that. So having a just culture where we can actually really learn from events in surgery, I think is really important.
Peter, from your studies, is there any evidence that these factors are at play when it comes to hierarchies and leveling up hierarchies?
Well, we haven't actually done any studies on that yet, Neil. But we are on the case, as you well know. I mean, we published widely in terms of MRCS performance and diversity, and there is differential attainment and things, and it's difficult to explain why that is, if I'm honest with you. I think for me it comes back to respect and respecting everyone in the team, irrespective of who they are, where they come from, what their role is. It's a mutual respect, and actually ensuring that message is got across, rather than just saying you're a valued member of the team. You have to actually act with all that non-verbal communication that we mentioned, just so important. And then, as you mentioned about the safety culture, again, we could spend a whole hour talking about that just on its own. And different cultures have different understandings, and there's gradients in terms of when they might stop or not. But mutual respect, just so important.
I think we talk about bias, and you talk about differential attainment. I think there was definitely conscious bias in the past. I think conscious bias has gone. We need to acknowledge, though, that unconscious bias still exists, and that's the challenge moving forward when it comes to whether different minority groups are affected by the hierarchy gradient. So that would be one of the next challenges, along with differential attainment. Accepting we've all got bias.
Can I just mention just one thing about the MRCS and the FRCS exams, which is interesting. There is no examiner bias, and I think that I really need to emphasize that. We've published 10, 15, 20,000 candidates, and the differential attainment is in the computer marked papers rather than the face-to-face. So it's not it's not biased from the examiners, and that's really important to stress that.
Well, we get lots of training. We get the training in unconscious bias and differential attainment before we become an examiner. It's a really important part of it. We should stress that as well.
Yep.
Okay, Jane. So the next webinar's got to be on safety culture, all right? But what's the next question?
Sounds
Brilliant.
good.
I will be coming back to you all again. Somebody asking, do you get feedback from your teams and other theatre staff, and do you check how they perceive the hierarchy, leadership in a given session?
So, Ginny, do you think 360 degrees work? Do people really say what they think?
I think that 360-degree feedbacks are dependent on, you all ask your people that you're going to get good feedbacks. The best 360s you get when someone else nominates them for you. Certainly with trainees, that's the more useful feedback. I mean, as part of my 360s, I send forms to my trainees to get feedback from them. And I think that's important to get that. As in the feedback from a team in theatre, I think that if a case has been difficult, I would debrief and talk to the staff and ask them about those points. I wouldn't do it. I don't do it routinely, so I'm not going to say that I do. I suspect that Peter does do it routinely at the end of every list. But the difficult case, then I think feedback on that, not just from what did we do well, what could we do better, but actually the personal feelings that people have. If there's been a poor outcome, are very important. So hot debriefs, yes.
Yeah. I think sorry, John, go on.
The other thing we think about feedback as being a written thing in portfolios, which is clearly very important, or appraisal, or at the end of the case. But thinking about how we could actually use feedback to help us and to lower hierarchies is by just asking open questions and actively doing that throughout a procedure, or throughout a ward round, or throughout a clinic, and just saying, you just put in the questions to someone, say, how do you think we're doing? Do you think we need to do anything different right now? And that's a nice way of keeping people engaged in a room as well, and getting them to help with your sort of situational awareness. So both, of course, if you've had a difficult case, a debrief at the end is beneficial for everyone, and certainly as a trainee, that's extremely beneficial to be able to learn those points and to record something in a portfolio afterwards. But then to enhance your working, to try and sort of get feedback as we go through, and it gets people engaged as well.
Okay, sorry, Peter.
No, I was just going to say, if you change the culture in your theatre, then you very quickly get into that mindset, Neil, that the nurses know, and the healthcare support workers know, that they can speak up and say, you know what, Peter, you're a bit off today. Are you okay? Or whatever. And it's that whole change in culture, rather than me being on a pedestal, which I've never been, obviously, but colleagues and things feeling that you can't give that feedback to them. You have to actively go about that for the whole of the team, from the healthcare support worker to the chief executive, and constantly reinforce.
Okay, Jane, we've still got a little longer. Some more questions?
Yeah, still there. They're still coming through as well. So for anybody that we will try and get to as many questions as we can, but I'm very sorry if we don't. We will try and pick up conversations on Twitter, and I believe this is a good opportunity to plug a session that I think Peter and is John also participating in tomorrow's session with Chorus. So
yes,
there is a session on safety and surgery tomorrow, which is not being run by us, but we are supporting, and Peter is speaking at. So if you are interested, please do try and join that. We've got time for a couple more, I think, just about. We've got somebody who's got a slightly different comment, which I think will be an interesting one. Sometimes reducing the gradient is misinterpreted, and we find ourselves in a situation, for example, where very junior members of staff are very rude to senior members of staff, empowered by flattening hierarchies and unchallenged for fear of accusations of bullying. How do we maintain our dignity in the face of such challenges?
Oh, very good question. Judy, would you like to start with that one?
It's a fine line, isn't it? And I think, you know, you still have to maintain your position as a consultant and not be fearful that you can't be fearful you're going to be picked up for bullying by having a challenging conversation with a trainee if you feel that their behaviour is not how it should be. And in that situation, I always say, if there's any fear, have a conversation with someone else with you as a witness. But you shouldn't be fearful of having those conversations. And you know, ultimately, you are responsible for their training. You are responsible for your patients, and nothing should compromise the patient's safety. You know, we've established that the hierarchy needs to be there. So yes, we need to challenge that.
And John?
Yeah, I think, you know, clearly bullying in the workplace is absolutely unacceptable. But also hijacking that that also undermines you know, all the progress that's been made on bullying. So I think if trainees are, you know, accusing someone of that unfairly, then that clearly undermines all the good work that has already been done in reducing bullying in the workplace. And I think, if you know, someone senior deserves respect because they have, you know, a knowledge, they have a skill set, they've spent many years getting to that point, and I think as trainees we must respect that. So and respect goes both ways, and it's I think Peter had that slide a little bit earlier, and that's something quite nice, really, just to sort of keep in the mind that if you know, senior members of staff are respectful to more junior ones, the junior ones will be respectful towards them. But I think it's absolutely unacceptable to go and hijack what's, you know, has been lots of improvements in bullying in the workplace. And it's all about respect flowing both ways.
Peter?
Respect. I think that's really important. And as John said, and as I put in that slide, it's a two-way process, you know. And if you do get caught by a colleague, and that could be a trainee, and I'm, you know, trainees are colleagues. They're not junior. They are the future of surgery, and you know, we have to respect that, and we have to empower them, you know. But if you do get you know, bullied by whoever, I think the first thing to do is actually not to make a snap, not to get that startle reaction, and to say something that you might regret. And that's very, very easy. You know, someone coming into your office and shouting at you or saying you're bullying me, whatever, and then you get that startle reaction, and you may have a knee-jerk response. So again, that's the human factors. That's the HALT, you know, the HALT that John mentioned, the hungry, angry, late, and lonely or tired. So the anger, I think I'm right, John. Is it 30 times you're more likely to make a mistake if you get into that angle, startled response?
Yeah, absolutely.
So I would step back, Neil. That's what I would do. I'd step back and say, right, okay, let's just think a minute, you know, because if you do say something you regret, you know, and you swear back or whatever it is, you immediately lose that respect cycle, and most 80% of people regret what they've said anyway, you know. So it's bad, you know. It damages your relationship with your nurses or your junior staff or whoever it is, and you're going to regret it afterwards as well. So stand back and think.
Yeah, that concept of limbic hijacking, that you go back to your base instincts, and that you basically, if someone is you know, aggressive towards you, you pretty much switch off your frontal lobe, go back to sort of basic aggressive instincts, and you will either fight back, well, it's the whole sort of fight or flight or hide, or sort of all these different reactions that you get. It's not quite a simple binary reaction, but it's limbic hijacking, and so it's about getting to, I guess, a place of safety, which is the same as we were talking about earlier, really, with the brief. You know, stop in all these situations, trying to pause for a moment, realize that we are human, and that we're going to go back to those instincts.
Yeah, draw a great big breath and pause. Jane, last question.
There are still so many good questions. We could probably keep going for another hour. I'm sorry.
Yeah. Need to make sure you drink your water and hydrate regularly as well. That's important.
Yeah, important. Yep. Make sure. Sorry. This is a really tricky one. I think a good one. I spotted one. Sorry. Is it fair to say that the culture adopted in theatre starts outside of theatre, and that we all need to look at our behaviours beyond the walls of the operating theatre?
I suppose it's sort of asking, are personalities already fixed and can they be changed? And Peter, what do you reckon?
Well, I think Neil, what I'd say is that the operating theatre is one of the most stressful places in the hospital. If you look at published study, in fact, there's a very worthwhile study that's worth looking at. It's by Panagiotti et al. In the BMJ 2019, 350,000 patients, and intensive care and theatre is the two most dangerous places in the hospital. So as soon as we walk into that theatre and we start operating, we are in a stressful environment. And I think most of us as surgeons, we thrive on that adrenaline, don't we? And the you know, that's slightly stressful, but it does change things. And again, John, we can start talking about cognitive overload and you know, reaching saturation point and things. So our trainees, if we teach them a new procedure, they will reach saturation much quicker than us. But yeah, I think again, Jane, it's not something we can really answer in a couple of seconds, really. But maybe another webinar on that, to be honest. Yeah.
So, John,
I've got some ideas.
Yeah, absolutely.
I'm going to ask you, say you had a major blow up with a member of your family on the morning of your big operating list. How do you get to that safe place if your limbic system is already overactivated by all those things that have been going on?
Well, I think the first thing is to be aware of it. That's a really important thing. And then I think often the ritual of surgery is a very useful moment to be able to sort of reflect on that and just to acknowledge. There's something that is quite ritualistic about when you're there scrubbing up. You've got 5 minutes. And maybe that's the stage where you can just acknowledge that all this other stuff has gone on, and you need to actively identify those things. You might say, look, okay, so I'm about to start a really big procedure. Lots of stuff has gone on at home today, and you know, maybe I'm in a rush. I haven't thought about things properly, so now's the time just to stop for a moment, and that's a great 5 minutes. I think you don't necessarily have to go, you know, take yourself away and come back again. That might be needed. You know, there may well be a day that you are too upset to operate, and that's a very difficult decision to make, I think, especially when there are lots of pressures on services. But then you have to think, if you were that patient or that patient's family, and you had yourself in that state operating, you know, would you really want that? Would you want that risk of error? Would you want that risk of harm? So I think it's a spectrum, really. I think you need to be aware of it. And I mean, certainly, I find that 5 minutes, you know, with my hands running underwater, a very sort of therapeutic few minutes to be able to identify what could affect the procedure. But maybe there are days where we have to take a real step back and go, well, look, if I was that patient or that family, it's a delayed procedure, and if you can delay it, well, maybe it would be worth it on that occasion.
I had one boss who called it morning prayers. Ginny, what do you reckon?
I was thinking that actually theatres is where, as surgeons, we're probably our happiest. I've had people tell me before that I'm different in theatre to outside of theatre, because it's like the happy place, more relaxed. It's where you want to be. It's where you want to be operating. It's also actually where, as surgeons, we get to spend more time with our trainees and, you know, one-to-one operating table and get to know them. And while you're doing the easier parts of the operation, have a chat. And really important to chat to your trainee about what they're up to, what they're like, build that relationship. And we have that privilege that other specialties don't, because we spend that one-to-one time with our trainees. So actually we're very lucky in that way to be able to have that communication and team working. But from the perspective of having a bad day and not operating, I think it's you can compartmentalize your life, and we've all done that when we've had difficult situations. And but it's acknowledging when you're not at the best place to operate and it's not safe. It's quite hard because as a surgeon, we never like to say we can't do something. But it's, you know, it's just having that awareness of when you're not at your best or when you're really tired. You know, days gone by when we'd be on crap all night operating and we'd carry on the next day. And actually now we turn around and say, too tired, can't do it, can't do the best. So we have to be aware it's our happy place, but it's fraught with difficulties if we try to do too much.
I mean, the other thing, Ginny, is to say, you know, no one knows how you feel. So if you are really tired and things, then it's certainly happened to me in the past. I've been up most of the night and I don't feel safe. And you go to the managers and you say, I'm really sorry, I don't feel safe. I can't operate things. I was like, well, you have to, you have a list. It's like, I don't feel safe, full stop. They don't know how you feel. And you're protecting, as you said, Jenny, it's about patient safety, number one, patient safety.
John, did you want to have a last word, and then we'll wrap it up then?
Yeah, I think it's more expansion, I suppose, on that a little bit before we wrap up. But the human factors is also, there's a lot more than just the individual. It's not just about the individual, and it's closely linked with ergonomics and systems and everything else. And this is, and this really is where it's a bit more tricky, you know, cancelling in cases in surgery. You know, if you're in other industries, there's redundancy built into the system. So you can say, well, actually, I'm having an off day today, and the other guy who's on standby comes in, and you don't have to give a reason at that stage necessarily, because you may not be in a position to do that. But as long as you say, look, I'm unsafe today. Whereas we don't really have that in surgery, and that's another side of human factors, which I'm sure we can talk about at length some other time. But it's not just about us. You know, error happens. We are human, and we have to accept that. And we all will have off days, but it's how we deal with that. And you can't take all the blame for it. And actually, sometimes we have to think, well, how can we change the system as well as ourselves?
Yeah, thank you very much. Well, I'm going to stop there and say thank you very much to Ginny, John, and Peter for their observations and for their wise words. I've learned a lot. It's been a great webinar. Thank you all very much. Thank you to Jane in the background and the rest of the college team for the questions. I think Jane would have said that she'd be very happy to help out getting back to some of you with some of your questions after the program, after the show. The show will still be available to watch if you want to watch it through again, or recommend it to friends. The title did say human factors, and we are humans, we're not robots. We have to bear that in mind. I guess we've been talking about happy teams in theatre. Happy teams are flatter teams, and that's clearly best for the patient. So thank you all very much. I'll leave there, and thank you for joining us.
Thank you.
Thanks very much, Neil. Very much appreciated.
Thank you.